Welcome to Chapter 9, entitled Quality Control in Pharmaceutical Care Guidelines and Protocols. Pharmacy practice guidelines are essential to describe pharmacy care structures and processes at the best evidence available. Guideline development is a laborious procedure that should be well organized and structured by a professional instance with the means to manage revisions and to support implementation in daily practice. During guideline development, practicing pharmacists should be involved as well as patients, other healthcare professions involved in the topic, the healthcare inspectorate, and health insurance companies as external stakeholders. Validated tools are available to grade existing evidence during the formulation of guideline recommendations, that is the grade. Checklists with acknowledged criteria, that is the agree to, can be used to optimize the guideline development process and to appraise guideline quality. Beside guideline development, continuous effort must be made for broad guideline implementation in daily practice. This can be done in pilot settings with critical feedback for an update of the guideline recommendations. E-health applications may be available to be used in the near future. Additionally, indicators can be used to collect information on the implementation of meaningful aspects and to monitor the progress during time. See Chapter 10. Next we will look at an introduction. Evidence from pharmacy practice research has shown the contribution of pharmacists to patients' health outcomes and medication safety. Additionally, there is a shift from remunerating pharmacists for their logistics services to compensations for their pharmaceutical care. Therefore, pharmacist services must be clearly defined and warrant uniformity at the desired level of quality. Consequently, beside pharmacopoeias for quality definitions of substances, guidelines for pharmaceutical care are needed. We will now look at terminology. In clinical practice, the terms standards and guidelines are often used concurrently. In some countries, they are distinguished according to the degree of obligation in following them. In the United Kingdom, for instance, standards are compulsory and must be followed, whereas guidelines usually describe best practices without being mandatory. Here we use the term guideline for documents with recommendations based on scientific evidence. After their accreditation, they need to be followed and thus become standards of care. Guidelines support providers, patients, and other stakeholders in making decisions on appropriate health interventions. As such, guidelines are developed by professional bodies within a national healthcare setting. This is done by a structured and coordinated program to assure and continuously improve the quality of care. Guidelines should be distinguished from protocols. Protocols describe specific behavior or technical performance in subsequent steps to implement a distinct guideline recommendation. They are mostly developed locally to support the staff members according to their needs. And now let's discuss pharmaceutical care guidelines, young discipline compared to others. Pharmaceutical care guidelines describe the processes and structures to be performed by pharmacists for a specified topic. See here some examples for pharmaceutical care guidelines. In the Netherlands, pharmaceutical care guidelines cover 3 domains. 1. Categorical domain addressing specific diseases such as diabetes, asthma, or chronic obstructive pulmonary disease. 2. Generic domain for specific forms of pharmaceutical care such as dispensing, central filling, consultation, or use of computerized medication surveillance signals. 3. Organizational domain describing care in cooperation with multidisciplinary teams of healthcare providers for topics such as palliative care, polypharmacy, or sharing medication information within the chain of healthcare providers. In Germany, The first guidelines with advices for pharmaceutical care in characteristic situations were acknowledged in 2000. These guidelines address specific forms of pharmaceutical care such as medication information, blood pressure measurement, dispensing, compounding, and self-medication. In Australia, professional practice standards formulate the values of the pharmacy profession and name the expected standards of professional behaviour of pharmacists. In 2017, 16 standards were restructured into 4 key streams: foundations of practice, providing therapeutic goods, providing health information, and delivering professional services. These standards clearly articulate the professional roles and activities that pharmacists have to undertake. In general, during the last decade, guideline development for all healthcare professions increased. At present, the Library of the Guidelines International Network (GIN) contains 6,400 guidelines. A membership to this network offers a number of benefits such as sharing of systematic reviews and evidence tables, access to the Guidelines International Network and Cochrane Library, and cooperation within the network for newsletters, training and mentoring, and conferences. Compared to guidelines for medical professions, the development of pharmaceutical care guidelines only started recently in most countries. For example, in the Netherlands, guidelines for general practitioners (GPs) have been developed for several decades, with at present about 100 authorized guidelines. These mainly address the diagnosis, treatment, and prevention of specific diseases. In contrast, the Royal Dutch Pharmacists Association started to develop guidelines on pharmaceutical care only as of 2008. At present, 5 guidelines are authorized, 1 categorical guideline, COPD, and 4 generic guidelines, dispensing, automated dose dispensing, compounding, and medication review. Additionally, 7 guidelines are in development: the categorical guidelines, diabetes, cardiovascular risk management, asthma, and the generic guidelines, medication surveillance, pharmaceutical consultation, pharmaceutical care at hospital discharge, and patient records. In Germany, the Working Group of the Scientific Medical Societies has 186 guidelines accredited for the different medical specialists. In comparison, there are 23 guidelines for pharmaceutical care available. We will now progress to guideline development. Guidelines are important tools in defining the quality of care and the implementation of new practices and improvements in healthcare. Consequently, guidelines should be developed when a. There is uncertainty in actual clinical practice, which can be reduced by scientific evidence, and b. The actual caregiving should be improved. Guideline development starts with the definition of the problem to be addressed. To collect existing evidence, key questions are formulated and translated into search criteria for a systematic literature review of existing evidence. This procedure is based on the conviction that guideline recommendations should be based on the best available scientific evidence to assess the benefits and harms of alternative care options. Additionally, the strength of the recommendations is determined by the quality of the supporting evidence. During guideline development in the Netherlands, there was an extensive discussion as to what guidelines should describe the standard care provided by nearly every pharmacist, or the best care that should be provided according to existing evidence, independent of the degree of implementation in daily practice. In the end, the choice was made for the latter, the best existing evidence. Thus, the deliberate risk was taken that the guideline recommendations may only partly be implemented by community pharmacists at the authorization date. On the other hand, after accreditation, guidelines should be followed as the acknowledged standards of care. Thus, they become tools for the implementation of the latest state of knowledge. When authorized, guidelines achieve a semi-legal status. Their implementation is not mandatory by law, but by the lack of other care definitions, they are used by external stakeholders to test and judge the pharmaceutical care provided. If the care does not meet the guideline recommendations, this may lead to disapproval by the healthcare inspectorate or remuneration loss from health insurance companies. By this, the implementation of professional guidelines is not voluntary, and consequently pharmacists are forced to quickly implement the recommendations in their daily practice. To enable this, during guideline development, practicing pharmacists as well as external stakeholders and patients should be involved early in the guideline development, and the guideline draft versions are broadly discussed before authorization. During this process, pharmacists can indicate bottlenecks in daily practice, and the external stakeholders are aware of these for their subsequent use of the guidelines. Additionally, pharmacists' associations should take the responsibility to support guideline implementation by their members. This covers, for instance, training courses for implementation. Technical and legal developments for the whole profession can also be stimulated by professional bodies. At present, apps and other e-health applications are used. The General Pharmaceutical Council in Great Britain developed an app to provide easy access for all pharmacists to the guidelines. This app is considered as a tool for the dissemination of the professional standards. This is a first step in their further implementation. In the Netherlands, summaries of the medical guidelines are available for smartphones to be used for anamneses. An example for technical and legal support is the development of uniform clinical rules by the Royal Dutch Pharmacists Association to support the signaling, management, and registration of medication surveillance signals in pharmacy computer systems. Another example is the facilitation of exchanging of meaningful laboratory measurements for medication surveillance. Additionally, to technical supply, the professional organization supported this process in contacting the JEEP's professional organization for their willingness and acceptance, and with legal aspects such as how to provide patients' consent. Next we will discuss the grade existing evidence. As clinicians are expected to dutifully apply the guideline recommendations, these need to be based on the best evidence available to warrant the highest benefit at the lowest risk. However, scientific evidence, if available, often is inconsistent. Thus, a rigorous system of rating the quality of evidence must be applied to grade the existing results according to the validity of the underlying studies. As pharmaceutical care guidelines are quite recent, examples of clinical guidelines are presented here to show the importance of grading evidence in guideline recommendations due to advancing knowledge. In the 1990s, guidelines recommended hormone replacement therapy, abbreviated as HST, in postmenopausal women to reduce women's cardiovascular risk. These recommendations were derived from observational studies. However, these studies had inconsistent results, and the evidence of cardiovascular risk reduction was of poor quality. A decade later, randomized controlled trials showed that hormone replacement therapy did not reduce cardiovascular risk, but might even increase it. It is assumed that a systematic appraisal of the evidence available would have led to less stringent guideline recommendations. A rating procedure furthermore would have revealed a knowledge gap and might have earlier stimulated trials on cardiovascular outcomes in hormone replacement therapy treated women. Beside this, the failure to recognize high-quality evidence can cause similar problems with false negative findings instead of false positives. For instance, Expert recommendations lagged a decade behind the evidence from well-conducted randomized controlled trials that thrombolytic therapy achieved a reduction in mortality in myocardial infarction. Therefore, a directed search for evidence during guideline development can help to earlier formulate recommendations based on the latest evidence and to stimulate the acceptance of new insights in clinical practice. A grading of recommendations, assessment, development, and evaluation, that is the grade, system has been developed for guideline development and is increasingly adopted worldwide to consistently rate the quality of evidence and the strength of recommendations. To make decisions, patients and clinicians must weigh up the benefits and risks of alternative strategies. The acceptance of the evidence also depends on their confidence of the results provided. To achieve transparency and simplicity, the grade system classifies the quality of evidence in 4 levels: high, moderate, low, and very low. Evidence from randomized controlled trials is rated as high-quality evidence. Subsequently, according to the confidence in this evidence, the ordeal may be decreased to a lower level. Reasons for devaluation are, for instance, study limitations, inconsistency of results, indirectness of evidence, imprecision, and reporting bias. Case reports and expert opinion achieve a very low level of evidence as they lack a control group and are highly prone to bias. However, when developing pharmaceutical care guidelines, this is often the only evidence available. The questions arising from guideline development reveal the lack of evidence and can stimulate new research to provide evidence for certain care processes. Corresponding with the quality of evidence, the grade system offers 2 grades for the derived recommendations: strong and weak. Strong recommendations are based on many high-quality randomized trials, and further research is very unlikely to change this confidence in the estimation of effect. Results from case series only without a control group provide weak recommendations. Here, further research is very likely to change the outcomes. Uncertainties then remain on the balance between desirable and undesirable effects. There is still variability in values and preferences and uncertainty on the efficiency of resources implied. In the Netherlands, automated dose dispensing came up as a new way to support pharmaceutical care. By the assessment of the GP, those community-dwelling patients are eligible for this service who use many different medications at several instances during the day and have problems in organizing their daily living. Often these services are provided by providers outside the pharmacy, and thus clarification of tasks, processes, and responsibilities was needed. The remuneration of this service and a lot of questions for quality assurance in this process forced the development of a guideline, automated dose dispensing systems. From cost perspective, medication should be supplied for longer periods and at less dispensing fees. The service started with dispensing for 1 week, and this was extended to 2 weeks. Relevant questions were, for instance, on how long medication should be supplied, for 1 week or longer, and how to deal with medication changes. With higher stocks of dispensed personalized medication packages, medication changes are more difficult to organize. For safety reasons, some medication changes might not be postponed. Possible solutions were to supply a revised personalized medication package or to replace the medication in question in the existing packages. The latter showed to be very sensitive for medication errors when cutting into the plastic bags and manually exchanging tablets. Consequently, questions came up on who should decide on whether changing supplied stock and on how to solve this regarding patient safety on the one hand and efficiency reasons on the other. As the service was new, no studies were available to rely on. Thus, The recommendations in the guidelines were formulated by expert opinion from pharmacists, prescribers, and patients. According to the grade system, this evidence is of very low quality and the recommendations based on this are weak. Consequently, the Pharmacists Association supported pharmacy practice research to provide evidence for these recommendations. Based on these results in future, the recommendations for this new pharmaceutical care service can achieve a higher validity level with stronger evidence. This example shows that guidelines are never finished but need continuous maintenance. This is one of the reasons why guideline development should be laid by instances with the means to manage, develop, and maintain the guidelines for their profession. We will now consider, from a first draft to a published version. Guidelines are developed in working groups. Preferably this includes pharmacists with special expertise on the guideline topic, preferably working in daily practice and engaged in the field to which the guideline applies. Additionally, other healthcare professions should be engaged who are also involved in the topic. And finally, as the care services should meet patients' needs and expectations, patients should be involved as early as possible. Guideline development in such extended settings contributes to the future acceptance and implementation of the guidelines. The guideline, COPD, for community pharmacists in the Netherlands was developed by the working group consisting of 3 pharmacists working in community pharmacies and 2 pharmacists who had experience with guideline development. The Royal Dutch Pharmacists Association, abbreviated as KNMP, had previously developed a procedure for guideline development and implemented a scientific control board to check on compliance to this procedure. During the guideline development, the draft was presented to a special interest group, abbreviated as SIG, for long-term conditions, involving pharmacists working in community or hospital pharmacies or industry. The final draft version was commented by a lawyer, general practitioners, medical specialists for lung diseases, nurses, physiotherapists, and the patient organization for lung diseases. The draft version was then published on the website of the KNMP and open for comments from the KNMP members for several months. The final version was developed in response to these comments and authorized by the Scientific Control Board for 5 years. It was announced that the guideline would be revised earlier if actual developments in pharmaceutical COPD care would require this. After authorization, pharmacists were invited to contribute new evidence for weak recommendations, and pharmacy practice research proposals could be submitted in annual research calls. The insights from new evidence will then be incorporated into the guidelines. Guidelines should have a logic and uniform structure with a clear and readable layout using understandable language. Often cards are offered that summarize the care provided on a certain topic. The implementation is more successful when the guideline formats are adapted to the readers. Thus, beside professional versions, also versions for patients in an accustomed language and addressing the care provided from their perspective are needed to manage patient expectations on pharmaceutical care. Today, guidelines are online accessible by websites and increasingly become available by smartphones. Pharmaceutical care guidelines in the Netherlands are structured in 7 chapters. 1. They start with an introduction on the scope of the guideline describing the type of patients, e.g., chronic obstructive pulmonary disease patients, and type of pharmacists, e.g., community pharmacists, involved in the care to be provided. Relevant guidelines from other healthcare professionals connected with pharmaceutical care are mentioned. Facts and figures are provided, e.g., disease incidence and prevalence in categorical guidelines, or the numbers of drugs dispensed annually in the generic, dispensing, Guideline. The guideline topic is defined and specified, e.g., the definition of dispensing in the corresponding guideline with the scope of drugs involved as prescription only, over-the-counter drugs, etc. 2. The second chapter describes the pharmaceutical care processes with specific recommendations on critical process steps. For the guideline, chronic obstructive pulmonary disease, this starts with an agreement between patient and pharmacist, including a patient record. Then specific care is described, including the drugs involved for the different chronic obstructive pulmonary disease stages and during exacerbations. Relevant issues in medication surveillance for chronic obstructive pulmonary disease patients are highlighted. Otherwise, the guideline refers to the generic guideline, medication surveillance, and specific topics for the dispensing of inhalation medication are mentioned. Otherwise, the guideline refers to the generic guideline, dispensing. 3. In this chapter, the internal and external working structures are described. In the guideline, dispensing, the internal structures name that pharmaceutical technicians may dispense under a pharmacist's responsibility, but that a pharmacist preferably is present or at least can be consulted during dispensing. 4. The fourth chapter describes the process during the development of these guidelines with the persons and organizations involved. 5. In a separate chapter, all abbreviations used are explained. 6. The sixth chapter elucidates the recommendations in Chapter 2 by summarizing the literature cited. Here, different results from relevant studies may be shown and discussed. 7. The last chapter shows the literature cited in the guideline. These guidelines are publicly accessible by the KNMP website. At present, there are no smartphone versions or patient versions available, but this is a future goal. We will now consider, agree on effective guidelines. As worldwide the number of medical guidelines increased rapidly, physicians were confronted with multiple guidelines on the same topics. Consequently, a tool was needed to assess the quality of guidelines and to differ between high and low quality. In 2001, the AGREE instrument, an abbreviation for Appraisal Instrument for Guidelines, Research and Evaluation, was published and translated into more than 20 languages. At present, pharmacists do not have to struggle with too many guidelines for pharmaceutical care, and as such, the AGREE tool might be not relevant for pharmacists yet. However, beside guideline appraisal, the tool has already been used by guideline developers to improve the quality of their guidelines, and the AGREE tool was shown to be effective in this. Thus, the second version of the AGREE criteria is recommended as a checklist during guideline development, as shown in Table 9.1. Pause the video and carefully scrutinize Table 9.1 summarizing the criteria of AGREE 2 before advancing to the next slide. Pause the video and carefully scrutinize Table 9.1 summarizing the criteria of AGREE 2 before advancing to the next slide. We will now consider stakeholders. Target users of pharmaceutical care guidelines are pharmacists. They can use the guidelines to organize their care services and to ensure high quality and highlight areas for improvements. In providing recommendations for clinical practice, they are also used as a professional aid in clinical decision-making and for education. To external stakeholders, guidelines show the services to be expected. In the first place, this is relevant for the patients. As pharmaceutical care services are relatively young compared to the traditional tasks of a pharmacist, they still need to become better known by patients, other healthcare professionals, health insurance companies, and the public. Guidelines are an excellent means to advertise pharmaceutical care to all these stakeholders. Patient versions of the guidelines should be developed that describe the specific services offered. Then patients can know what to expect from their pharmacists. They may use the guidelines to ask for specific pharmaceutical care, to compare pharmacies according to the implementation of the guidelines, and to actively choose pharmacy services. These activities belong to patient empowerment and self-management, both developments needed in modern healthcare policy. Secondly, the government and healthcare inspectorate and healthcare insurers are relevant external stakeholders. The government uses guidelines for policy and is mainly interested to prevent unnecessary care, costs, and undesired practice variation. Practice variation is shown by indicators, see Chapter 10. The Healthcare Inspectorate uses guidelines to control the quality of care and to detect safety issues. Healthcare insurers use guidelines as a description of the care to be expected from healthcare professionals when contracting certain care services. We will now consider guideline implementation. It has been addressed before that guidelines are a tool for the implementation of innovation by summarizing the existing evidence in recommendations for healthcare providers. To this, the guideline recommendations have to be accepted and supported by the practicing pharmacists. This can be stimulated by involving pharmacists within the guideline development and appraisal. See above. Certain characteristics support guideline implementation, as shown in Table 9.2. Pause the video and carefully scrutinize Table 9.2 summarizing characteristics of effective guidelines before advancing to the next slide. For the development of the concept guideline, diabetes, in community pharmacies in the Netherlands, practice tests were organized. To this, groups of community pharmacists were formed with interest and experience in diabetes care. These pharmacists were invited to score the degree of implementation for the specific recommendations in their daily practice. In groups and assisted by a trainer, they developed an implementation plan and defined individual implementation goals to further or better implement the recommendations in their pharmacy. During the implementation process, critical success factors, barriers, and means to overcome those were noted and discussed within the group. The information from this pilot group was used by the Pharmacists Association to revise guideline recommendations or to develop toolboxes for implementation. This example shows that the measurement of meaningful aspects from the recommendations, indicators, provides information on how to measure the successful implementation of the guideline recommendations. See Chapter 10. Thus, the development of indicators should be embedded in the guideline development. Thank you.